she has a large polyps in the ascending colon.
Hello, do you hear
planned
me?
for EMR ESD today.
Hello, do you hear us?
Yes, we can hear you, Dr. Majid, Dr. Ammar.
Okay, thank you. So I'm here with Dr. Ammar, and this patient is a 61-year-old, as you just heard, and she was referred for a large ascending colon polyp that was found after a colonoscopy for pain. So we'll go, we already have the weather restriction, we've been waiting for you, but we'll go some basic steps whenever you get a patient with a large polyp. So first of all,
Majid, sorry for
yes.
for interrupting. You are an Ammar there, so I'm asking about
yes.
when you want to classify a polyp according to different MBI and what do you have. Can you classify and tell us how do you classify it with different views?
Yeah, sure. So, sure, Dr. Hamad. So first of all, you need to have a very straight scope to have a better manipulation, especially in the right colon. And the second thing, you want to have a very good bowel preparation before you undergo any endoscopic resection attempt. So this patient has a very large ascending colon polyp. As you can see here, this is the cecum here. And this is just in the mid or proximal ascending colon. And the polyp, as you see here, is very large, extending over 1, 2, 3, threefold maybe. And it is slightly raised, so that's Paris classification 0-2A, which has a low risk of submucosal invasion. And on top of that, this is granular, as you can see here. So granular ST in the right colon, the risk of submucosal invasion, according to the Michael Bork study group, is very low, less than 3%. And if you want to change and go to MBI here, so we can see here that the polyp is J-net gray. We'll go to near focus as well. So we are now using the near focus from Olympus system. And this polyp, as you see here, is J-net class 2A, as I think you would agree with this, Dr. Ammar.
So as Majid said, doing an
So question to you, Majid and Ammar, also for, so it was the same topic covered in your lecture. So what are the things that made you decide to do an EMR instead of ESD in this patient?
So this is the perfect lesion for piecemeal wide field EMR. So it's a Paris 2A, so flat lesion.
Dr. Ammar, but it's just we can't hear you. Yeah, so now it's better. If you can make the microphone closer, please.
Sure, sure. Can you hear me now well?
Yes.
Yeah?
Yes.
Can I take my mic?
Okay, can you hear me now?
Yes, we can hear you.
You can hear me, yeah. So this lesion that Majid is doing a great job is the classic lesion for wide field piece, wide field EMR. It's a Paris 2A flat lesion with a granular morphology. So, and it's in the proximal colon, it's in the mid-ascending colon. It's about probably around 60 to 50 millimeter. It goes across two folds, half circumferential. So this is the perfect lesion for piecemeal EMR. With the NBI classification, as Majid showed, it will be a nice type 2, J-net type 2A. So this is a very benign disease. If we look at the Nick Berger study from Michael Berg that I showed you in the lecture this morning, actually this lesion will be a 0.7% risk for a surprise cancer. So it's actually 99.3% benign just on, even without doing any optical assessment, just by location, granularity, and the morphology of Paris. So this is the perfect lesion for piecemeal EMR. So the chances of us getting it wrong is really less than 6 in 1,000 cases. So if we do 1,000 cases, we probably get only 5 wrong, surprisingly, according to the literature. So Majid did a very good job. He started with a submucosal injection, was using saline with methylene blue, and we have a diluted epinephrine, 1 in 100,000. He started from one edge and started taking resection piecemeal with good margins of normal tissue. So Majid, I think we'll do some more resection now.
Yeah, so it's just that's
Dr. Majid nicely demonstrated. No cap, it's a no cap day.
Yeah, so we don't have a cap. Normally, I would like to have a cap in this situation. Majid also did a great job by retroflexing in the right colon. I don't know, can you see if you can do again?
Sure.
Yeah. So he actually retroflexed, and we spent a good amount of time assessing the lesion. So it has good access also with retroflexion. Probably will finish most of the rest of the lesion on retroflexion. where we have a much more stable scope and we can visualize the lesion behind the folds. We will improve the axis by utilizing dynamic submucosal injection, where we use the injection to improve the axis.
Dr. Majid, do you do most of your EMRs with cap assisted? And what is the rationale?
Beautiful. So here you nicely can see the lesion. So we can see very well the oral side of the lesion where we're going to continue working. There is a valley in the middle where we're still going to work on the right side of the screen where we haven't done any work. So most of the work we did within the center and the left side of the lesion, and we'll still have some work to finish here, but we probably, maybe hopefully inshallah, maybe 15 more minutes. We were waiting. We could have finished the lesion, but we wanted you guys to see. But
Okay, well,
this lesion, hopefully less than half an hour should be finished, which is really good for the patient where you can improve access. We can do more cases. So if you want to spend an ESD in this lesion, I think you need a good 2-3 hours maybe.
Thank you.
And then at the end, the patient is not better off.
Thank you very
having,
much, Dr. Ammar. We'll
an
get
outcome
back
at the
to
end.
your case. We have to move to, I think they are want to
Fantastic.
us, yeah,
Thank
to
you.
the